So this is a very, very basic understanding of glaucoma. All right, so if you guys remember, now we're talking about the posterior segment of the eyeball, particularly right here. Okay, so what is glaucoma? Obviously glaucoma is actually a group of diseases and not just one disease. A lot of times people think glaucoma is just a high pressure. That's actually not the case. Some people have low tension glaucoma, low pressure, and they can still have glaucoma. Some people have other types of glaucoma, like pigmentary glaucoma, pseudoexfoliation glaucoma. Those are all different. But in general, for the purpose of knowing if a patient has glaucoma, that means their optic nerve is changing. It's progressing. And so I have this, I don't know if you guys seen this in the rooms, and sometimes I'll just pull this up. It's a very easy way to explain. I'll pass this around, but the reason why we like to take optos is it's really good for patient education. We can show patient what we're looking at. Particularly, we're looking at the optic nerve. The way we grade and look at the optic nerve, there's you'll hear us saying like CD ratio. It's not because we like to listen to music, but it's really cup to disc. Okay, it's I gotta say something else, but no. Okay, so it's cup to disc ratio. Cup, kind of the illustration is looking at a donut, right? You have a hole in the donut. That's kind of the information that's going through, the nerve. And then there's the tissue around it, and that's the cake part of the donut. So we like to see a ratio of the circle, the hole in the donut, to the entire size of the donut, around 0.3. That's kind of the general average of the population. Okay, some people are naturally smaller, 0.1. Babies are usually a little bit smaller, but some people are born larger, 0.8. No matter what you're born with, everyone's a little different. If it's changing over time, there means there's some trauma to the nerve, or there's some physiological change to the nerve, and that's what we call glaucoma. So one thing great about optos is that we can actually monitor change, and we can actually show patients, hey, look, and sometimes I'll pull that out and like, hey, look, your nerve is about 0.8, so that means if things are changing, it's really hard for us to go from 0.8 to 0.9 without seeing a lot of drastic change versus a 0.2 ratio to a 0.6. Then we can really see that changing. So typically for us, if it's more than a 0.5, usually I'll have them come back for extra testing. Okay. And optic nerve, basically kind of what Dr. Dave mentioned, is transmitting visual information to the brain. If then there's not a lot of nerve tissue there, then it's the information is going to go to the brain slower. And we actually have tests now. We actually have, you guys know, the diopsis machine that's looking at transmitting speed and how the information is getting into the brain. And glaucoma is one of the things that you're not going to really notice pain unless it's actually a different type of glaucoma. There is one type of glaucoma that can cause a lot of pain, and that's what we call closed-angle glaucoma. And so I'll explain that later. So this is the optic nerve, transmits information in the brain. So the optic nerve, there's a whole series of disease. Glaucoma is just one type of optic nerve disease. There's other nerve disease like optic atrophy, optic neuritis. Those are typically more associated with autoimmune sometimes, multiple sclerosis, that we see a lot. And those are more where the myelin that we talked about, they decrease myelin, or the inflammation is slow, or there's swelling or acute inflammation of the nerve. And that can cause trauma to the nerve. So anything that's changing, the tissue losing, that's what we call glaucoma. Who is at risk for glaucoma? Pretty much everyone, to be honest. That's why a standard of care for eye doctors, no matter where you go, is to take eye pressure. There's several ways we can take pressure. Obviously, on an infant, we're not going to be doing eye care on a baby. So for us, physicians will do what we call tactile. So we'll use our thumb and kind of, assess whether or not the pressure between the left eye and the right eye, it feels soft or it feels the same. And that's a very, very gross measurement of pressure. The other thing we can do is you might hear the blowing test, it's like this puff of air. They still do this at certain offices where you had to sit there and you don't know when the air is coming, but the air is coming and you blink or you get really startled. And basically it's assessing the force. It pushes air to the cornea and it assesses how much force is coming back. And that determines the pressure. And it's very similar to the eye care, but eye care is just really subtle and you don't really feel it. African Americans have a little bit more higher likelihood of getting one type of glaucoma, open angle glaucoma. Asians are more likely to have more narrow angle glaucoma in certain cases. So depending on different ethnicity, there is a little bit more genetic ethical factor. The people over 60 naturally have a higher likelihood, and that the reason why is if you guys remember this anatomy, so everything is sort of related to the pressure in the eye, and so the pressure is build. I don't know if you can see my cursor. If I can move the cursor, no, I can't. Anyways, so the ciliary body creates pressure, and then it's what we call the aqueous humor, and it kind of circulates. It doesn't really go to the back of the vitreous. It's two separate things. So it circulates in the front, and what happens is in one of the structural called trabecular meshwork, there's these meshing, right? It's kind of like pantyhose, those meshing, and so the fluid drains out through the meshing. So as we get older, unfortunately, because the cataract, the lens here gets wider, right, as the tree trunks, what naturally does is sometimes it pushes the iris forward, okay? So iris is pushed forward, and in the trabecular meshwork, it happens in this, what we call a structure. It's pretty much, it looks like this, a structure, what we call the angle of fluid drainage, and this is what we call trabecular meshwork. And so what happens is, because the lens is being pushed up, the structure is being pushed forward. So then the drainage is more narrow. And that's what we call narrow angle. And in some cases, that is so narrow that the iris naturally is very sticky and actually will get stuck to the back side of the cornea. Okay, so if it gets stuck, then it can't get unstuck, right? Because it's so sticky. So then that's what we call emergent. That's the only emergent glaucoma. All of a sudden the pressure rises up to 70, 80, and there's steams coming out of the eye, in the front of the eye, because of steam. Because of, of the fluid, it can't drain out, so it has to push its way to the front to try to let go. What's that?
Can you unstick it? Can you unstick the iris from the front of the back of the cornea?
So there's different ways to help that. A lot of times it requires surgery. Sometimes reduces the output of the fluid to control the output of the fluid, and then decrease the aqueous production as well. So I mean, there's different ways, but that's the number one reason we can certainly prevent that, because if you have a routine eye exam, we can catch it whether or not this is changing over time, right? That's why sometimes I'll have patients come back and I do a procedure called gonioscopy. We'll go over different special testing next week, but basically allows me to angle my light using a lens that I put in front of the cornea so that I can see where they're at. And we can actually do that also on the OCT machine as well. We can measure that structurally. So if it's really, really narrow, then I'm going to send them out for a procedure so that the fluid can drain out a different method. And the procedure typically requires a little zap, a puncture, a hole in the iris so that the fluid can drain out somewhere else. Okay, so
is that a procedure you could do, Dr. Shen?
Currently, at the state of Washington, us ODs, we cannot. However, I was at a lecture. I did get my certification for this. I know how to do it, and so until legislators, pass that we can do it, we'll be doing it in our office. And it's really nice if we could do it in our office because then the patient don't have to go somewhere else. Typically there's about 2 to 4 months wait time. So if anything happens between then, you know, they could be ended up in the ER. And this would be an ER case. Yeah, so currently there's a couple states in the US that ODs can actually perform this type of procedure. So we're just hoping.
What's it called?
Laser peripheral iridotomy. Yeah, so LPI, basically it just kind of punctures. And usually they'll create this little hole on top so you don't really cosmetically see it.
So far away from each other.
Yeah, so what happens, yeah, good question. What happens is the fluid, you know, we're measuring fluid of the anterior chamber right here, right? If the fluid increases to a certain amount, what happens is it can compress the nerve. And so some people, it can take a lot of, their nerve can withhold a lot of pressure. That's why some people they have their eye pressure in their 25s or 20s and they don't have glaucoma. And that's a condition we call ocular hypertension. It's kind of like you have high blood pressure, but it's not causing any damage. Other times, you know, their pressure could be 19, which is we consider fairly okay. 14 to 19 is kind of where we expect most people to be at. But then the nerve is still changing. And so it's pretty much how you're built. And there has been studies correlating keratoconus patient with higher increases of glaucoma as well, because their structure overall is weaker, you know, collagen and so on and so forth. So if it happens out here in the front, it can cause thinning in the back as well. And people with nearsighted, high nearsighted, everything's stretched out. So this, the back could be stretched out as well. So people who have a family history of glaucoma, a little bit more evidence showing more maternal side, and looking at just the different types of, if your mom has open angle, you might have a little bit higher likelihood. Sometimes everyone's structure is born a little bit differently, so the angle could be a little irregular, you know, in terms of structure with the irises, so that can cause maldirection of the flow of the fluid going out and exiting differently, and that can cause an increased pressure as well. So we actually, the importance of doing gonioscopy in our office, we do that a lot here. Steroid user, one of the complications for steroid is it can cause increased eye pressure. That's a well-known complication. If you have had a lot of intramuscular, you know, steroid, or you are on steroid for rheumatoid arthritis or medication you're on, that can, over a course of time, can increase your eye pressure. So anybody who's prescribed steroid, they actually know one of the complications is making sure you need to check your eye pressure. If you had an injury to your eye, so sometimes that injury can cause a dislocation of the iris. So it can create a widening of the iris, or sometimes it can change the iris shape. So that can actually block the fluid, the drainage. So anything that can cause a physiological change can cause glaucoma as well. And people who are really high pressure, or people who have really low pressure, can also develop glaucoma, because everything is about blood flow into the nerve as well. So if things are, if your blood pressure is really low, then that can cause the nerve to, you know, be changed. Yes.
What's a low pressure? Because keratoconus patients always have super low single-digit pressure.
Oh, we're talking about blood pressure in this case.
Oh, blood pressure.
Yeah.
Okay.
If their blood pressure is super low, you know, like maybe 90/50, that's fairly low. Then that can, over a course of a period of time. Or if they've had high pressure, but their cardiologist prescribed a lot of medication to reduce their pressure so low, that have shown to cause some changes as well. So, yep. So glaucoma is essentially the nerve tissue is responsible for our peripheral vision. Okay, if the nerve tissue start to change, or we start to see a change in overall tissue structure, patients can start to lose their peripheral. And the first area that they start losing is actually the nose area, nasal, inferior nasal. And so a lot of patients don't realize that they can't see part of their visual field because they have two eyeballs. The nose naturally blocks a segment of it, so they don't really realize that they're losing part of their peripheral vision. That's why when they come in for workup, we actually do a functional test, the visual field, where we actually occlude one eye, so we're not testing both at the same time. We're occluding one eye, and then we're having them look center, and then there's big flashes of light coming from the side, and whether or not they can see it, like clicking. It's very preventable in terms of this fast progression. You know, obviously, if it changes, there's some things that we can certainly do, and everything's about early detection. You know, that's why we have patients constantly coming back for additional testing, because if we can catch it early, then we can at least help these patients to slow down this progression of disease. Couple of things for glaucoma we use, you know, I explained Optos, and then, you know, the eye care OCT. We also scan the optic nerve. We also scan the macula, the ganglion cell. There's 10 layers in the retina. The ganglion cell is the most outer layer, meaning anterior. And what happens is if there's compression, that layer is going to change the fat for the first. And so we measure sensitivity of the ganglion cell. We measure using the OCT of the ganglion cell layer, and then the diopsis actually, the ERG machine can actually look at the sensitivity of the ganglion cells as well. Pachymetry also help because if you have a very, very thick cornea, you know, obviously it's going to take more force to get that amount of force back. You know, if we push certain amount of strength, that certain amount of strength is reflected, but if their cornea is really, really thick, then we had to push harder. So corneal thickness actually varies. So for keratoconus patients, it's a little bit harder, but for patient who has really, really thin cornea after LASIK or after PRK, then naturally we're not pushing as hard to gather our eye pressure. So their measurement, every time we take our eye pressure, it's calibrated to a corneal thickness of 550 microns. So if the cornea is really, really high in their 600, then sometimes we'll know to kind of manually adjust it a little bit. And that just gives us a different data point. Okay. So basically a healthy nerve is on the left and a nerve with glaucoma is on the right. So there's a couple of different ways to treat glaucoma. In terms of the net pressure, the two ways we can really alter net is decrease input, so decrease production, or increase output. You know, increase the fluid that's draining out so that the net pressure is reduced. So there's a couple medications that target one pathway or the other. The first line of therapy typically targets the outflow, and then if the pressure is not under control, then we typically will add or adjust medication. Usually when they are on glaucoma medication, I would always create a target eye pressure for the patient so that we know what to work on. And we will change that per patient. If the medication we're still not getting our target goal, and things are still changing with our scans, we will sometimes refer patients out for different type of surgical intervention. But for the U.S., the first line of therapy is topical med.
What are some of the names of those topical that you might prescribe for?
So there's 4 categories. The most common one I prescribe is a class of prostaglandins. Prostaglandins are known to increase the uveoscleral outflow. Basically, you don't have to know that, but basically the trabecular mesh where the meshing, it opens up, it creates larger a hole so that more fluid can go out. And so that's pretty much the first line of therapy. We like it because it's only once a day. All the other glaucoma medications are at least twice a day, or 3 times a day. And so the first once a day, it's good for compliance. Patients will remember it better. Some of the complications of that is increasing lash growth, which some people actually really like, and some redness. So some of the names that you'll hear common is Travatan Z, Travatan, Zalatan, Lumigan. So those are all, and there's some preservative-free along those lines as well. So that's usually the first line of therapy. Okay. And then in terms of surgery, if their patients on more than 2 medications, usually I'll consider them to refer them for surgery, because I don't want patients to put 5 drops in each eye per day, because medications can cause a lot of dryness because they have a lot of preservatives. And obviously we're a dry eye clinic, we're trying to work on their dry eyes, but if all these medications inducing dry eyes and leading to discomfort, patients are not going to be very compliant with the medications. So in those cases, I will refer them for different types of surgery. So what does that mean for us? One of the most important thing to monitor glaucoma is making sure they do come back for evaluations. Once they're on medications, I typically like to check their eye pressure between 3 to 4 months. If they're really, really stable, things are not changing at all, I usually monitor them twice a year. Okay? So if they're on medication, you look on their exam history, and they haven't been in for over a year. That necessarily means that they need to come back. Because if they're on medication for glaucoma, or they have glaucoma, they know they have glaucoma, then these patients need to be followed up very regularly. And then yearly photographs, or even more. If they have some sort of bleeding sometimes that can cause from glaucoma, we want to image them a little sooner. Yeah. Any questions?